So on behalf of the heart team at EA, we will present a live-in-a-box case done about a month ago. And the patient is a 79-year-old male who presented with significant shortness of breath, NYHA functional class 3, and a recent hospitalization for heart failure. He had a history of bypass surgery about 15 years ago. I had a 4-vessel bypass then. He was found to have severe aortic stenosis with a peak rating of 85 millimeters of mercury and a valve orifice area of 0.4. An ejection fraction of about 40% with ischemic cardiomyopathy. And his comorbidities included COPD, emphysema. He had a right bundle branch block and hypertension. He was evaluated by the heart team and it was decided to proceed with transfemoral TAVR. This is his angiogram. See severely diseased right coronary artery, a patent graft to the diagonal, and patent lima with a good runoff, and a patent graft to the posterior descending. And this is his invasive hemodynamics of severe aortic stenosis. Echocardiographic appearance, he had impaired left ventricular systolic function, typical color continuous wave Doppler of aortic stenosis. And moving on to the CT for screening angiogram, we see a heavily calcified tri-leaflet tricuspid aortic valve with calcifications extending to the outflow tract of the left ventricle. And we can see that in this very nice model. Some calcification, heavier calcification on the non-coronary cusp. And here we see the measurements. We had a diameter of the annulus at 20 by 29, fairly oval, with a perimeter of 80 and a perimeter-derived diameter of 25.7 millimeters. We see his peripheral angiogram looked fairly good for a transfemoral approach from both sides. We decided to go from the right side. The plan was to go transfemoral with a 16 French central sheath. We would use a self-expanding platform instead of a balloon expandable for the risk of annulus rupture with a heavily calcified aortic root. We would pre-dilate with an 18 millimeter ZMED balloon and post-dilate if necessary, but fairly conservatively just to prevent any risk of root injury. Obviously, the patient with a pre-existing right bundle branch block was also at a high risk for developing complete heart block, and that was also in our mind. So we move on to the case. Πάμε στο πρώτο. The case it's a bit edited, so for time, so I will be directing our staff here to move ahead from time to time. So we use the crossover approach to with initial puncture on the left side and the lima catheter into the bifurcation of the aorta, and using a roadmap of the right iliofemoral angiogram, insert a 6 French sheath on the right common femoral artery. Nowadays, we have switched to try to go more with echocardiographic guidance for these punctures. Here we see the initial angiogram for the access site, making sure everything is okay. We already have a 7 French venous sheath on the left side, and the 7 French arterial sheath on the left side as well. And we see that the implant site and the puncture was as appropriate, very appropriate. We use usually 2 proglides for closure, pre-closure of the artery. So this is the first proglide being deployed and already deployed. And second proglide is going to be inserted. Ναι, so we can, μπορούμε να προχωρήσουμε λίγο παρακάτω. Να πάμε στο επόμενο. Okay, so here we have the insertion of the 16 French central sheath under fluoroscopic monitoring without any difficulty. And next we will proceed with crossing of the valve. Πάμε στο επόμενο. Προχωρήσουμε στο επόμενο. So here we have a Amplatz AL2 catheter inserted into the left ventricle. We have hemodynamics reassessed. A exchange length coronary J wire is inserted into the left ventricle. We try to get it to go into the, not to stay in the center of the valve, but go into the commissure to rest nicely at the edge of the valve. And then we proceed inserting a pigtail catheter, and over the pigtail catheter we insert a confida wire to make sure that we're not entangled with any subvalvular apparatus of the mitral valve. Here we have a pigtail inserted, and we see the hemodynamics, as we saw before, suggesting a severe stenosis. We do a hand injection just to make sure that we're not caught in any that we're free into the left ventricle. And then we advance the confida wire. Here we have the confida wire inserted, and it's resting nicely into this commissure there. So this is what we'd like to see. So before we do the balloon pre-dilatation, we check the valve for that it's correctly preloaded. And once we're confirmed that, then we proceed with, this is we advance an 18 by 40 ZMED balloon, and we proceed to do pre-dilatation under rapid ventricular pacing. Yeah, you see very calcified aortic valve. Nothing is moving on the leaflets. And so rapid pacing, have drop in blood pressure. It's a small balloon, but what we wanted to do is give it a gentle massage on the valve to make sure that we don't have any serious difficulties expanding the Evolut Pro valve once we're there, and then if need be, we'll do a post-dilatation. Here we have advancement of the inline sheath. Initially we had some difficulty, we had to come back, and then once we aligned better, we were able to insert without difficulty. Here we tried to, but we pulled it out, and then we came slightly out, and then more. We can proceed. Here it's going to go. It's in this view. It's going to go straight up now. Yep. So, okay. So the valve is being advanced. Without difficulty, and we'll be over the arch shortly. One second. We have the. We went too far ahead. Let's go back a little bit. Maybe go back. Go back. A little bit. Λίγο πίσω ακόμα. Okay. So here we have the valve in position, and the valve is gradually being deployed. While pacing at 140. It's a stable position. But we see how the valve is compressed from the significant calcification. So the depth seems to be acceptable. We don't seem to be more than 5 millimeters in depth from either side. About 5 to 6 millimeters. And the valve will be deployed at this point. We loosen the tension on the system and on the wire, pull back the pigtail, and proceed with full deployment. We have stable hemodynamics, and the valve is being deployed now. So we see clearly that the valve is compressed from, it's a bit oval in its opening. We're going to assess hemodynamics. We'd like to assess hemodynamics. So here we reinsert the centron sheath, and we'll have a pigtail inserted into the left ventricle to reassess hemodynamics and see how we're doing. Meanwhile, we've done an aortogram. We showed mild aortic regurgitation, but we were not very happy with the expansion of the valve as it is. So this is the aortography. That's not the aortogram. Here we are. So it's very compressed, the valve. So we're going to check hemodynamics. Here we have the hemodynamic recordings, and we see that there is a small difference between left ventricular end diastolic pressure and systemic diastolic pressure. And especially after an extra heartbeat, these almost come together. So in part this is because of diastolic dysfunction, in part is some degree of aortic regurgitation. In any case, we didn't have stenosis on the valve. There wasn't any gradient, peak-to-peak gradient to make a note of, but we decided to go ahead and do a post-dilatation with a 20 millimeter balloon. And here the balloon is being advanced. It's in position at this point. And here we have rapid pacing and balloon inflation, full inflation. Modified somewhat the inflow of the valve. We're very happy with that modification. Again, we didn't want to be very aggressive because of the severe calcification of the annulus. And this is repeat hemodynamics, some improvement. There is still some, after an extra heartbeat, that there is some, but more or less we have diastasis between the diastolic pressures. To some degree, the patient has left ventricular diastolic dysfunction, so we don't expect to see tremendous differences. And with the fact that we didn't have significant aortic regurgitation on post-aortography, we're happy with this result as it is. Again, many times patients do have diastolic dysfunction with high filling pressures, and that doesn't mean that they have significant paravalvular regurgitation. And you can see here very nicely when the patient is in stable rhythm that we have good distance between the diastolic pressures, and even here and here. So with that, we eventually concluded the procedure. We removed the Peripheral. And we had mild regurgitation from this side there, but it was acceptable. And we proceeded with closing of the implant side, and we had no complications. And the patient eventually did not need a pacemaker, even though he had a right bundle branch block. Maybe in part because of the calcifications and so on, the valve didn't impinged so much on the septum. Thank you very much.